Hello, my name is Katie Lovett, and this is my Unit 2 Case Connections video. First of all, I apologize for my voice and my appearance. I've been really sick with the flu for about a week, and I was waiting to do this until I got better, but I need to be able to take my Unit 2 exam, so I just have to go ahead and do it in this state, so I'm sorry. I chose cases 3 and 4. And for case 3, it involves a 5-year-old boy who went to his pediatrician for an annual well visit. The patient's mother shared that the child was frequently sick as an infant, and she is also now concerned about his persistent thirst and chronic fatigue and frequent urination. A glucose loading test was performed, and this tests how well an individual's body cells are able to absorb glucose. And the blood samples were obtained at time 0 and 1 hour after the test. The child's baseline blood sample at time 0 showed serum insulin levels at 0.8 milliliters per milliunits per liter, and this is well below the control level of 4 to 8 milliunits per liter. 1 hour after the glucose loading test, the patient's serum insulin level was 5 milliunits per liter, and this is also far below the normal range, which is 29 to 51 milliunits per liter. So these results, along with the child's clinical symptoms of polyuria and polydipsia, strongly suggest that the child has type 1 diabetes. This is also known as insulin-dependent diabetes. And this is a chronic condition in which the pancreas produces little or no insulin. Because insulin is required for glucose to enter cells and produce energy, this suggests that the patient's blood glucose levels would be elevated, since the glucose administered in the glucose loading test would have remained in his bloodstream and not been absorbed into his cells properly. The state of hyperglycemia would also explain his symptoms of increased urination and thirst, and this is because his body is compensating for the excess levels of glucose in his bloodstream by trying to flush the excess glucose from the body in the form of urine, and then this causes him to be excessively thirsty, which then reinforces the cycle of increased urination and subsequent increased thirst. And his fatigue can probably be explained by the body's inability to properly process glucose, which can lead to decreased energy, since that is the source of our energy. From a biochemical perspective, the decreased secretion of insulin in type 1 diabetes is due to the progressive destruction of the pancreatic islet beta cells, and these are responsible for producing insulin. So this destructive process can cause severe insulin depletion, leading to hyperglycemia because of the excess hepatic glucose production through glycogenolysis and gluconeogenesis, along with the decreased cellular uptake of glucose. Hexokinase and pyruvate kinase are two regulatory enzymes which would be active in this child's current condition. And moving on to case number 4. Case number 4 involves a 2-month-old infant, and she presents with jittery spells several hours after breastfeeding. She has otherwise been healthy up until this point, and her mother reports that she has had no food other than breast milk since she was born. Recently, she's only been sleeping for about 2 hours between her feedings. Her lab results at her pediatrician's office were consistent with hypoglycemia, but otherwise showed nothing remarkable. The infant was given epinephrine. There was no increase in blood glucose, but there was an increase in blood lactate. So her physical exam confirms hepatomegaly, which is enlarged liver, and her blood glucose levels did increase after breastfeeding, but she could not maintain blood glucose levels within a normal range during fasting. Based on this information, this patient is most likely suffering from glycogen storage disease. Glycogen is the storage form of glucose in our bodies, and glycogen storage disease causes glycogen to be stored improperly in the body, and it is caused by a genetic enzyme disorder which is inherited from both parents. This baby's symptoms appear to be most consistent with type 1 glycogen storage disease, which is also known as von Gierke disease. I'm not sure if I'm pronouncing that correctly. Symptoms of this class of GSD include enlarged liver, which she has, hypoglycemia, which the baby has, and high lactate levels, which she also demonstrated. And It can also be characterized by enlarged kidneys, slow growth, delayed puberty, osteoporosis, and mouth ulcers, but she did not have these yet, but may exhibit them as she gets older. The patient's symptoms are not consistent with the other three diagnosis options. Hereditary fructose intolerance is a condition that affects one's ability to digest the monosaccharide fructose, which is simple sugar. These individuals will show signs of the disorder in infancy when fructose-containing foods, such as fruits and juices, are introduced. This baby had only had breast milk, so this makes this diagnosis very unlikely. And symptoms of this would be nausea, bloating, abdominal pain, diarrhea, and vomiting, none of which the child exhibited. Galactosemia is a disorder that affects how the human body processes the monosaccharide galactose. Small amounts of this simple sugar are present in many foods, but it is mostly a part of lactose, which is in dairy products and many baby formulas. Again, she has not had any formula since birth, only breast milk, so this also makes this diagnosis unlikely. Signs and symptoms of galactosemia would be jaundice, slow weight gain, lethargy, liver damage, and abnormal bleeding, again, none of which the patient had. Glucose 6-phosphate dehydrogenase deficiency is a genetic disorder that almost exclusively affects males. This involves red blood cells breaking down prematurely, and this is due to a defect in the aforementioned enzyme, glucose 6-phosphate dehydrogenase. The most common medical problem resulting from this is hemolytic anemia, and this is where red blood cells are destroyed faster than the body can replace them. Symptoms include paleness, jaundice, dark urine, fatigue, shortness of breath, and a rapid heart rate, none of which this child exhibited. And also she is at a much lower risk given that she is female and this disease primarily affects males. Those are my two case studies for the Unit 2 Case Connections assignment. Thank you.